بالظبط. دلوقتي معانا انترناشونال سبيكر في محاضرة تيشو از ذا ايشو ذا كاتنج ايدج. هي المحاضرة مسجلة، هيقولها دكتور نيل نافاني. هو كونسلتنت ريسبيراتوري واسوشيت بروفيسور في يونيفرسيتي كوليدج لندن. اتفضلوا يا جماعة.
Hello everybody, and thank you very much for the very kind invitation to deliver this presentation. My name is Dr. Neil Navani. I'm an interventional pulmonologist based at University College London Hospital in the UK, and I'm an associate professor at University College London. Today my presentation is going to be on tissue is the issue, the cutting edge, and really focusing on areas of tissue acquisition patients with lung cancer. I have 5 key objectives for this presentation. One, to confirm the importance of tissue acquisition in patients with lung cancer. Second, we'll go through some of these techniques for sample acquisition. Third, we'll talk about some of the innovations that are happening in bronchoscopy in particular. We'll also talk about the importance of rebiopsy, and also mention circulating tumour DNA and how tissue is complementary to ctDNA. So first of all, we now have at least 9 and coming up to 10 now biomarkers for our patients with lung cancer, for which there are approved, FDA-approved treatments. So for each one of our patients, particularly in an advanced disease setting, it's really vital that we try and acquire enough tissue so that we can measure these biomarkers on all of our patients with non-small cell lung cancer. The fact that there are now so many biomarkers means that realistically we should be looking at next generation sequencing of our tumour samples in order to answer the question about all of these biomarkers. And that really does put the spotlight on the importance of tissue acquisition. But tissue acquisition is not just acquiring tissue for diagnosis and molecular biomarkers, but also can provide very important information about disease stage. So, if we do not stage patients accurately, we know that this results in worse survival. Conversely, if we stage people accurately and rapidly, this can result in much better outcomes for our patients. And really to get the most accurate disease stage, particularly of the nodes and the mediastinum, that requires invasive sampling, usually with endobronchial ultrasound. So, accurate staging of non-small cell lung cancer relies on tissue. And this is not surprising, because when we look at the performance of CT scan and even PET-CT scan, we can see that the sensitivity of these techniques are relatively low. So an invasive sampling technique, such as endobronchial ultrasound, can really raise the sensitivity and improve the staging of the mediastinum. And this is particularly important now that we are selecting patients for neoadjuvant treatment. So what should our test for tissue diagnosis ideally involve? Well, it should have high sensitivity and specificity, it should allow all biomarker analysis, it provides information, it provides it is minimally invasive and obviously very few complications. Ideally it would be widely available, it would be carried out in the outpatient setting, it should be easily repeated, and ideally needs to be cost effective. But in real life, of course, there's no perfection and only real life options. So let's go through some of those options that are available to us. And I think you'll all be familiar with all of these very standard techniques that are used for tissue acquisition and staging. Endobronchial ultrasound and endoscopic ultrasound provides access to lymph nodes within the mediastinum. Endoscopic ultrasound and EUSB, so placing the EBUS-scope in the esophagus, also allows access to the left lobe of the liver and also the left adrenal gland. Percutaneous lung biopsies are commonly performed and provide very good tissue, and thoracoscopy and pleurocentesis we'll also talk about shortly. So in terms of the data for CT-guided biopsy, we have a number of studies that are available to us. You may be familiar with the BATTLE trial, which is a US-funded study that was an umbrella trial that looked at 151 patients, and specifically there was a biomarker analysis paper published, and this showed that about 83% of the biopsies were adequate for biomarker analysis. And there was a significant complication rate, with 15% pneumothorax and 9% of patients requiring a chest drain. Other retrospective studies have suggested a higher yield, so over 90% for molecular biomarker testing. You'll be aware of endobronchial ultrasound and the importance of EBUS for the diagnosis and staging of lung cancer. As you know, it allows us to sample mediastinal lymph nodes, station 2, 4, and 7, but also the higher lymph nodes, 10, 11, and even perhaps some station 12 lymph nodes, particularly on the right. It allows us to sample any FDG avid, higher or mediastinal lymph node. In addition to that, EBUS should be performed when there is any enlarged mediastinal or higher lymph node, regardless of FDG avidity, if the nodal status affects the management. Also, all central lymph tumours should undergo mediastinal lymph node sampling, and any tumour, even if it's peripheral, greater than 3 centimetres. And this is because of the importance of picking up nodal metastases. So when we use EBUS, are the samples suitable for molecular testing? Well, we conducted a national study of over 700 patients and showed it was suitable in more than 90% of occasions, and we can obtain these worm-like cores that provide very adequate tissue for next-generation sequencing. And more recent data has suggested that the yield for next-generation sequencing is proportional to the number of passes, and we should be carrying out at least 6 passes to maximise our yield for all of our biomarker analysis with endobronchial ultrasound. So several studies now have looked at this and have shown that these small samples from EBUS and CT-guided needle biopsy are feasible for next-generation sequencing. This nice study from Japan looked at over 100 patients and compared CT-guided biopsy to endobronchial ultrasound and transbronchial biopsy, as well as surgical resection, and they showed that success rates generally were very high for adequate analysis of next-generation sequencing. Probably maybe the highest for EBUS samples, but also very high for others as well. We can also do PD-L1 testing with endobronchial ultrasound. So we looked at over 500 patients and showed that this was successful in more than 95% of cases. It was noted that older patients had higher failure rates, but this may be related to fewer passes. So endobronchial ultrasound is perfectly feasible for next-generation sequencing and also PD-L1 testing. So how do we select a biopsy site? When you have a patient with a peripheral lung lesion, but also a central mediastinal node, we need to take into account a few factors. We want to carry out the procedure with the least risk, but also the highest yield. We may also need staging information that could be vital for patient management. We need to take into account patient factors, patient preferences, and particularly as well patient fitness. We need to take into account the size. Clearly yield is going to be lower for smaller lesions, but also the location. So there are certain lesions, so for example the aortopulmonary window, that are not accessible to endobronchial ultrasound. We should also avoid necrotic areas. We know that these areas have low yield for DNA, and we should also avoid bone metastases. This is important because these samples need to be decalcified before analysed, and this can damage the DNA. So there are several considerations for our patients when it comes to choosing a site for biopsy, because we want to maximise information about disease stage, but also quality of tissue for biomarker analysis. We looked at over 1,000 patients in the UK that underwent tissue acquisition, and we showed, interestingly, that pleural fluid was not a reliable way for biomarker testing. We found that patients undergoing pleural fluid aspiration were twice as likely to have failed initial biomarker analysis compared to endobronchial ultrasound. So this is something perhaps for us to bear in mind in our clinical practice. If we want biomarker analysis for our patient, pleural fluid may not be the best substrate. Even if we are using a cell block technique and spinning down the tumour, which was done routinely in this study, it is still not as reliable as endobronchial ultrasound. So in my practice, what I tend to do is reserve pleural aspiration for patients who are symptomatic or for whom staging the pleural fluid is important. And in those patients who are having a pleural drain, consider taking a further biopsy sample so we do not delay the results of molecular biomarkers. Let's talk about some of the things that are progressing in interventional pulmonology. The first thing to say is that we should be using endobronchial ultrasound more for parenchymal lesions, so not just lymph nodes in the hilum and mediastinum, but you can be surprised at how much we can sample in the peripheral lung with standard endobronchial ultrasound. My technique is particularly in the lower lobes, that you can inject saline, which dilates the airway and introduce the endobronchial ultrascope further into the lung. And it's surprising, particularly in the lower lobes, how far we can progress. I look for airways that are greater than or equal to 5 millimetres adjacent to a lung lesion, and then be able to target that airway using that technique, and reliably can sample even lesions like this within the lung parenchyma. And this example here, we sampled the lung lesion. Now, peripheral bronchoscopy is increasingly an important technique. It allows us to sample the peripheral lesions, and also at the same time we can place an endobronchial ultrasound and stage the mediastinum. So particularly as screening gains traction, these peripheral bronchoscopy techniques are increasingly important. So here we're navigating using navigational software to a lesion in the right upper lobe. This is the navigational view, this is the real endobronchial view, and we can see here we've gone up into RB1, the apical segment of the right upper lobe, and then into a subsegment here. But we're stuck here with the bronchoscope. The bronchoscope is wedged into a subsegmental airway of RB1 here. And the virtual software tells us that this is where the lesion is. So what we did in this case was placed a radial EBUS probe down into this subsegment. We were able to watch this with under fluoroscopy to confirm where we were, and then we also use in our institution cone beam CT, and this allows us to confirm the position of the tool in relation to the lesion. And interestingly here, you can see we've just missed. We just missed on the cone beam CT here the tip of the radial ultrasound versus the nodule here. And what we were able to do in this case, I think it really shows the value of cone beam CT and fluoroscopy, is pull the radial probe back, reposition it slightly, and re-advance the radial probe down an adjacent airway. And then we can confirm that we're in the lesion using radial EBUS that shows we're there, and then introduce forceps and a radial probe. We can also confirm the position using cone beam CT, and we can see now we've got a much more satisfactory position with evidence of the tip of the tool of the lesion, tip of the tool in the lesion. So a much more satisfactory position. Once we're happy with that, we can then introduce our forceps here, and we can take some samples of the lesion. We can do this on multiple occasions, sampling small peripheral lung nodules. We routinely use biopsy forceps. We also use brushings, and I think something that's really important that I would encourage you to use as much as possible in the future as well is the use of a cryoprobe. So we were able to, here we just have a picture of the bronchial brushings, but we also were able to place the cryoprobe directly in the lesion. We always confirm the position, and we can extract, using the cryoprobe, a large sample of tissue which was confirmed as adenocarcinoma.
We want to thank Professor Neil Navani for his active participation in our Congress, and Professor Neil had active participation through World Congress of Bronchology and Interventional Pulmonology in Madrid, in Marseille last year, and active participation also in Madrid in the European Congress of Bronchology and Interventional Pulmonology in last May, and we want to thank him for active participation in our Congress.
طبعا ان شاء الله يسعدنا ويشرفنا في هذه الجلسه ان الاستاذ دكتور بروفيسور هاني حسن بروفيسور in عين شمس University to introduce the role of surgery in advanced lung cancer.
حابب ارحب بالدكتور هاني حسن، هو اخ وزميل فاضل، هو رئيس قسم الثوراسيك سيرجري في طب عين شمس، والتوبيك اللي هو هيقوله دلوقتي والحقيقه هي جراي زون بالنسبه لنا كبالمونولوجيست، ان احنا عندنا في رولز اوف ريسكتابيليتي بالنسبه لللان كانسر. زملائنا في الثوراسيك سيرجري عندهم ديفرنت بوينت اوف فيو. الحالات الادفانسد اللي بيبقى فيها انفيجن للقراينه، انفيجن لللور سيرد اوف تراكيه، البايلاترال تيومر ماسز، فهيوضح لنا في المحاضره ان شاء الله كده البروسبكتيفز، وان شاء الله كالعاده محاضره باذن الله فروتفول وقيمه. شكرا، اتفضل كده.
بسم الله، أنا متشكر جدا على الدعوة الكريمة، والحقيقة أنا بتشرف جدا يعني في التواجد معاكم كل سنة. يعني نحاول إن شاء الله بشكل سريع كده نشوف رول اوف سيرجري في الادفانسد لانج كانسر. طبعا جزء من العيانين اللي عندهم ادفانسد لانج كانسر will be irresectable، إنما it will not be the rule إنه كل عيانين الادفانسد كانسر are irresectable. يعني سريعا هو lung cancer is the leading cause of death among all cancers in developing and non-developing countries. Non-small cell lung cancer represents the majority of cases. The application of staging, TNM classification with the 8th edition was applied nearly 6 years ago. In TNM classification, the majority of patients included in the database were from Europe and Asia, and a good number of patients to build upon the database. As we all know, this classification, what's important about the TNM classification, the 8th edition, what's the most important is size of the tumor. So every centimeter will count. And this is an important change from the 7th edition. If we look at stage 3A, historically stage 3A was always labeled as N2 disease. But this is not the case in the new edition. There are 5 possibilities of stage 3A. Only 2 of them are N2 disease, but the other 3 possibilities are locally advanced lung cancers, T3 and T4, with an N1 or N0 status. So what's a T4 disease? So these are the possibilities of a T4 disease. Tumors which are large in size, more than 7 centimeters, and this will be the most common indication of surgery among all T4 disease. And this is why we as thoracic surgeons are operating on more T4 disease because of this change in TNM classification, so we are operating on tumors larger than 7 centimeters. An ipsilateral tumor in one lobe and metastasizing to another lobe. This is another T4 disease and another indication of surgery. Tumors invading the diaphragm, we'll talk about this, invading the spine, invading the carina. And the top right box, this is the most common indication of irresectability in lung cancer. Tumors invading the mediastinum, esophagus, trachea, and great vessels. So if the T component is important, we need to know how to size a lung cancer. You can see in this example that a mediastinal window will show you that the tumor measures only 4.7 centimeters, so it's a T2B, while on the lung window it measures 5.2 centimeters, so it's upgraded to a T3A. So the ISLC recommendation is to always use the lung window as a measurement of tumors. I always put this slide as, well, my colleagues have gone through the importance of MDT, and I think MDT is not a luxurious option. MDT affects patient survival, and it's the best way to treat patients, and lung cancer is not an exception of this. So I think there are some dangerous pathways. You get an operable lung cancer, and it doesn't pass through a surgical opinion. You can see an oncologist, and it may have some optimal results. The other way around is also dangerous. So you get a non-oncology referral to a surgeon, and the surgeon performs the operation. He gets the good results, tumor all comes out, and the patient doesn't have a chance to explore other systemic options and adjuvant therapy. And as we were talking now, there's a boom in these systemic therapies, and patients need to have all these options available on the table. So this is the optimal combination of an MDT. The core personnel are the oncologist, the pulmonologist, the thoracic surgeon, the histopathologist, and the radiologist. And you can have additional specialities which give you more space for patients. When I was involved in putting the guidelines for an MDT approach for non-metastatic non-small cell lung cancer in the Middle East and Africa, and we published this probably a couple of years back, we considered that T4N0 and T4N1, which are stage 3A lung cancer, they should be given a chance of upfront surgery after MDT discussion. So this is a classic example, or a large right upper lobe mass. It's a T4, 8 centimeters. It could be still operable if it's properly staged and shows localized disease. You can have large tumors. This is a large right upper lobe tumor. It's 9 centimeter in size. One of our surgical tips is when we take this out, we never keep the vessels to be cut at the end, because if these large tumors hang on vessels, they can strip them off the atrium and cause a fatal bleeding. This is another large tumor in the right lower lobe, and as we mentioned in the last session, we need to have a good hilar and mediastinal lymphadenectomy done in these patients because they have higher chances of occult nodal disease, and this needs to be diagnosed after the operation. So this is another indication for surgery. You can see a left upper lobe tumor and another metastasis from the same tumor in the segment, the apical segment of the left lower lobe. So this is another T4 tumor. Can have a lobectomy for the primary tumor and a sublobar resection for the metastasis. And that's what we've done for this patient. You can see from this study, it's an Asian study, and they looked at about 4,700 patients with T3 and T4 disease. And they looked at prognosis with different reasons for T4 disease, and they've shown that the best prognosis are patients who've got T3, T4 cancer because of an additional nodule. So you've got a small tumor with a nodule in the same lobe, which is a T3, or a tumor with a nodule in another lobe, which is a T4. Those will carry best prognosis other than other causes of T4 disease. A tumor like this, patient who's got a right lower lobe tumor invading the spine. Obviously, to get this all out, we need our neurosurgeon's friend to help us because this will need a spinal resection. And again, he will need to have an opinion. Can this all come out? Because if we think that this tumor will not all come out, we will not achieve an R0, upfront surgery should not be the option. Probably of the mediastinal invasion, the only possibility that we can consider complete resection in patients with great vessel invasion is invasion of the superior vena cava. So in these patients, we can perform a sternotomy or a hemiclamshell incision, take the right upper lobe tumor out, and reconstruct the superior vena cava after partial resection. These are tumors invading the mediastinum on the left side, and hoarseness of voice is one of the most specific signs of lung cancer irresectability. And in this patient, the left vocal cord is paralyzed, and we should not attempt surgery in these patients because there is invasion of the aortopulmonary window. So, carinal invasion, an airway invasion, this is one of our great areas of interest. And there are different types of carinal resection according to the location of the tumor, which part of the bronchus is invading. But the key point in all these patients is to take the whole tumor out. Can you achieve an R0? That is the key question. If you can achieve an R0, you're probably going to give some benefit to this patient. If you cannot, then surgery should not be attempted. These are all types of carinal resections that we perform. And sometimes you need to aid your operation by stopping ventilation, and cardiopulmonary bypass and ECMO are substitutes to the lung during carinal resections. We always prefer, if logistics are available, a veno-venous ECMO because we use less heparin and there is less post-operative bleeding. So these are some of our cases with dealing with T4 lung cancer. This is a 72-year-old male with a reasonable performance status. He's got a left lower lobe tumor, which is proven to be an adenocarcinoma. His lung functions are fair. He needs 4 anatomical segments out, so his post-operative predicted FEV1 is a low risk for surgery. And you can see the tumor occupying the left lower lobe here. There's query involvement of the of station 11 or station 10 with a low SUV, but this will come out during surgery. So the tumor intraoperative is found to be invading the diaphragm, and hence we take the left lower lobe out, take part of the diaphragm out, and replace the diaphragm by a Prolene mesh. And we perform our hilar and mediastinal lymphadenectomy. And you can see the diaphragmatic muscle just hanging on the lobe down there. With another 1 centimeter satellite tumor in the same lobe, but that does not affect the T staging, goes home quite quickly. He's got a complete resection and he's got free diaphragmatic tissue. None of his driver mutations are positive. He receives adjuvant chemotherapy because of the size of the tumor and the local advancement. And his PET, more than a year after the operation, shows freedom from any residual disease or sign of recurrence. And we can see that diaphragmatic involvement, this has been upgraded in the most recent TNM classification from a T3 to a T4, but we need to know that diaphragmatic invasion is not all one entity. So if patients are having a diaphragmatic invasion into the peritoneum, yes, you can take it out, but the prognosis is much worse. And the reason why it's been upgraded to a T4 in the recent 8th classification is because of poor prognosis. This is another tumor. It's an 8 centimeter left lower lobe adenocarcinoma. Again, it's completely resected and it's still a T4 because of size. This is a 68-year-old male with a lower tracheal adenoid cystic carcinoma invading the carina, so it's a T4, and invading the right main bronchus. So he's received chemotherapy for a year with no improvement, so we go in, we resect the lower 2 centimeters of the trachea, we cut the right main bronchus just above the right upper lobe takeoff, cut the left main bronchus proximally, and perform a new carina. And this is immediately post-operative, just on the operating table, how it looks like. We've done an anastomosis. This is the new carina. This is the right upper lobe just up there. That's the bronchus intermedius. There's total lung preservation. That's middle and lower lobes down there. Again, that's the carina. And that's the left main bronchus. The tumor is completely resected, and the patient needs no adjuvant treatment. So when to perform it? This is the Bartevel experience from France, operating on T4 patients for a very large period of time, 25 years. And the main point to emphasize on is complete resection, no nodal disease. If there's no N1, N2 disease, and you can get a complete resection with a T4, these are the best prognostic factors to go on and have an operation. Other than that, you won't get good results. Again, this is a Bartevel experience of 30 years experience for T4 lung cancer, and the two main factors are complete resection and no nodal disease. So these are the T4 tumors we've discussed. If you can take it out, if they're properly staged and preoperatively, you can have good prognosis. So I will conclude that surgery for T4 non-small cell lung cancer is feasible, promising results combined in a multimodality protocol in a specialized center. Two main factors are completeness of resection and absence of N2 disease. These are cornerstones to better survival in T4 patients, and obviously these patients should be discussed in an MDT. Thank you.
شكرا دكتور هاني على ال very good illustrative lectures. ومتهيألي كده واضح قدام حضراتكم ان اي حاله تيومر كان بي ريفيرد فور سيرجري فور ريسكشن. ويعني كده ما فيش حاجه ليها اكسبشن. تي 4 وصلنا لغايه 8 سم وبرده كان بي ريسكتد انفيد ديافرام، ما فيش مشكله. ماشي عشان ما تعملوش ريفير شكرا يا دكتور هاني. في سؤال بس بعد
شكرا دكتور هاني على الاليجنت برزنتيشن. انا بس كان ليا سؤال بالنسبه للحالات اللي هي تي 4. هل كان في السنتر في الاسم في الاكاديميه فولو اب للبيشنتس اللي هم اوبريتد؟
يعني احنا عندنا هم طبعا T4 patients they are not the commonest patients دكتور هيثم. يعني احنا obviously this lecture is to talk about advanced surgery for a selected group of patients. There will be a group of T4 patients who are irresectable, who are inoperable. The follow-up of these patients is crucial. Obviously, no patient with operated T4 will not have multimodality therapy. They can have sometimes neoadjuvant, especially in Pancoast tumors, neoadjuvant chemo or chemoradiation. And if they don't receive neoadjuvant therapy, and even if you take the whole tumor out and there is no nodal disease, they still will benefit from adjuvant treatment. So yes, they need to be discussed and they need to be followed up properly.
سؤال يا دكتور أيمن اتفضل.
Thank you, Dr. Hani. Actually, it's very impressive approach. My question is how it's very crucial to exclude N2 disease. How would you be satisfied with this exclusion in such a situation? And also, you refute the literature. What is happening there?
Okay. This is a good question. It is important.
Are you going to exclude only by PET scan, or are going to have pathological, I mean EBUS staging, or are going to do mediastinoscopy?
Okay. The proper assessment of the mediastinum before operating on these patients is crucial. And obviously the chances of nodal involvement in these patients are higher than patients with early stage lung cancer. So you need to be cautious. Patients who've got any sign of activity of nodes on a PET CT, which is obviously an essential investigation before operating on these patients. Any patients with any activity on PET CT will definitely need invasive mediastinal staging. Do I think that invasive mediastinal staging can be performed efficiently by an EBUS? Yes. If you've got good service, you can properly stage the mediastinum. I think you can properly stage the mediastinum beyond the mediastinoscopy. With the mediastinoscopy, you probably got 2 stations on the left, on the right, on station 7. But an EBUS can go beyond that and can properly stage the mediastinum. So before operating on these patients, I have a very low threshold to invasively stage the mediastinum to make sure that I'm not dealing with an occult N2 disease.
Yeah, that's the point. Thank you.
شكرا دكتور هاني.
شكرا.
بسم الله الرحمن الرحيم. بداية بتشرف ان انا بمثل مستشفى صدر العباسية وسط هذه الكوكبة العظيمة من علماء مصر في الأمراض الصدرية، وبوجه الشكر للأستاذ دكتور عوض تاج الدين مستشار الرئيس للصحة والوقاية بالدعوة الكريمة لمستشفى صدر العباسية وتمثيلها لي شخصيا، وكمان بشكر رئيس اللجنة المنظمة الأستاذ الدكتور الاستاذ دكتور ابراهيم رضوان، وبشكر الاساتذه الاستاذ دكتور اشرف المراغي والاستاذ دكتور هيثم سامي والاستاذه الدكتوره ايمان جلال. ودلوقتي في محاضره مسجله الإيبس جايدد بايوبسي اوف ميديستاينال ليمف نودز بروفيسور نجارونا ماتو. نجرجونا ماتور. اتفضل.
Good morning. I'm Dr. Nagarjuna. I head the Department of Pulmonology at Tertiary Care Hospital in Hyderabad, India. Warm greetings from India. Before I start, I should thank my friend Dr. Haitham and the organizing committee for giving me this opportunity to be talking in this prestigious congress at Egypt. So my talk is titled EBUS Guided Biopsy. I'll be talking about the different techniques and our experience in this new technique. This is a new era in EBUS sampling which we have adapted over the last couple of years. So before I start my conflicts of interest, though I have received grants earlier from several companies for lectures, this talk I have no direct conflict of interest or disclosures to be made. So the first thing which we have to understand is what is the need for this so-called EBUS biopsy. Since its introduction in 2000s, early 2000s, whenever we talk EBUS, linear EBUS, we talk about something called as EBUS TBNA. That is transbronchial needle aspiration, where we put a needle and we get a cytologic material from the needle. Now, we have slowly moved from TBNA to what we call as getting a biopsy from the lymph node. So, why do we actually need to get a biopsy? If you look at the data which has been generated over the last couple of decades, if you look at the diagnostic field of EBUS, it varies. It ranges from anywhere between 70% to 90%. For diseases like carcinoma, it is very good, 90%, whereas for diseases like lymphoma, it is much lesser. Similarly, for benign conditions like TB and sarcoid, sometimes the yield is not as good as that is for carcinomas. So we want to improve our yield further. That is the reason why we now started doing a procedure called as an EBUS biopsy. That is the first indication. Second is now, as we all know, we have gone into the era of molecular studies for lung cancers. Whenever we diagnose lung cancer, it is important for us to get a lot of tissue so that we can do all these molecular extensive studies. So we need more tissue. These are the two reasons why we require more tissue. One, to improve the diagnostic yield beyond what we have with EBUS TBNA. Two is to get more tissue for performing these molecular studies. As the slide says, we always want more because the more the merrier. That is what is always there. That is true even for pathology. So if you give a bigger tissue, bigger piece to the pathologist, they'll be happy. They'll give a better diagnosis. The oncologist will be happy because they can do more studies. If the pathologist is happy, the oncologist is happy, the diagnosis is better, and then we are happy. Now we have to change with times. So mediastinoscopy has been the gold standard for sampling mediastinal lymph nodes. Since EBUS TBNA has come, EBUS TBNA has become the gold standard. Now in the last couple of years, EBUS biopsy has come, and slowly EBUS biopsy is replacing EBUS TBNA for some indications. So this is how the evolution of EBUS has taken place. Now how can we get a biopsy? How can we get a histologic sample from the lymph nodes? There are three broad techniques. One is called a needle biopsy. Core biopsy using the needle. You have several needles which are commercially available which can give a tissue, not an aspirate. Then you have something called as a forceps biopsy. So you have forceps which can be passed through the channel and then we can get a biopsy. Then the latest is the mediastinal cryobiopsy, EBUS mediastinal cryobiopsy. I'll briefly talk about each of these techniques. So starting off with the needle biopsy, that is EBUS needle core biopsy. The three needles which are there in India which can be used to get a tissue, not an aspirate, are one, the Olympus needle, which is the 19G flex needle, the ProCore needles by Cook Company, 22 and 25G, and the latest is the acquired needle Boston, 22 and 25G. So Olympus needle, how is it different from the conventional needle? 19G needle is a needle with a larger diameter. Because it has a larger diameter, we can get a tissue from the lymph node, not just aspirate. Not only that, the diameter, it was also more flexible, so we can reach nodes which are more angulated, which require more angulation, for example, the 4R and the 10R. And also it is better echogenic. If you can, I'll show some videos where we can see that it is more echogenic as compared to the conventional needles. The disadvantage being that the larger the tract, more will be the hemorrhagic artifact, more will be the bleeding. So this is a picture which shows that it can be angulated better, it is more flexible. This one is an image of the 19G flex needle, and this is with the 21G needle. Though it is larger in diameter, it is actually more flexible than the conventional 21 gauge needles. Will it actually improve the yield? Always. The studies which have been published do not say so. This is one RCT where we have randomized samples to patients to 19G or a conventional 22 gauge needle. They have shown that though the larger tissue is obtained, the diagnostic yield is not different. The ProCore needles, if you can see the design, there is a groove on the top of the needle. Because of this groove, it will cut the node and then you will get a tissue. You have 22 and 25 gauge needles, you don't have larger needles. The studies which have been published till date, they have shown that there is some increase, numerical increase in diagnostic yield of the core needles. However, this was not statistically significant. The latest is the Acquire Boston needle. This is one which we have felt that is one of the very good needles to get a tissue. It has three prongs and it is set to cut the node as we puncture. Since its introduction in the gastro, they have started using this exclusively for getting biopsies, and we also have used it in a large number of cases to get tissues, core biopsies, and not just aspirates. Again, available in two sizes, 22 and 25 gauge needles. This is one of the initial cases where we have done. If you can see the cores, you get large cores which get cut by the shaft of the needle. This is one case where we have diagnosed malignancy using the Acquire needle. The benefits are that of this needle is that it has a higher core biopsy accuracy rate as compared to the 19G or the ProCore needles, better diagnostic yield, and it is a very simple procedure to perform. Now, this is about the core biopsies. Now, Broncos company is launching another needle which is 18 gauge, which is even larger than the 19 gauge needles. And that will probably give us more biopsies as compared to these conventional needles. The second technique is the forceps biopsy. So here there are three steps. One, you do a normal TBNA. Second is you have to create a tract. This tract is created. I will talk about it later again when while talking about cryobiopsy also. You use a quartering knife or you use a larger needle like a 19 gauge needle. And once you do a tract, you fix the scope, remove the needle and put the forceps, thin forceps. You have dedicated forceps. We use a spy bite forceps which is used by the gastroenterologist for the cholangioscopes. It's a very thin 1 mm needle forceps. It passes through the channel of the eboscope and then you can pass it into the node and take a biopsy. This is a study from our Indian colleagues where they have done transbronchial forceps biopsy. EBUS forceps biopsy when Rose was negative, rapid onset was negative, and they have shown that of the 30 cases, 20 cases they could diagnose on the forceps biopsy. This is one of our cases where we had a hilar node or a mass which is FDGFed, no other sites. EBUS was done earlier, it was inconclusive and then referred to us for sampling. So here we did what we call as a forceps biopsy. You can see the video, you can see the forceps going inside. See the forceps opening and then you make a couple of revolutions inside, close the forceps and then take. You can see the forceps jaws nicely open. So with this you can get a tissue from the lymph node. This is an image with the forceps open. Diagnosis was Castleman's disease. Surgery was done. A lot of papers. It is not a new technique. It has been there since 2008. Again, if you can see, the diagnostic yield is better for sarcoidosis and lymphoma as compared to a conventional TBNA. However, the problem is that with forceps biopsy, you get very small pieces and you get a lot of crush artifacts. Now, the latest technique is what we call as a cryobiopsy, EBUS mediastinal cryobiopsy. So, as we all know, this works on the Joule-Thomson's principle. You have a cryoprobe. When we freeze the cryoprobe, the tissue around it gets stuck to the cryoprobe, and then when we pull it out, it gets avulsed. Now, the current generation cryoprobes use carbon dioxide, and for EBUS lymph node cryobiopsy, we use a 1.1 mm cryoprobe, not the 1.7 or 2.4 mm cryoprobes. This is important. We use a mini cryoprobe. So the technique, the what all tools we require for a cryobiopsy, we would obviously require an EBUS scope. We require an ERBI cryo module. Then you would require something to create a tract. At our center, we use 19G needles. You can also use 21G needles, or we can also use a electrocautery forceps to create a tract. And then once you create a tract, you would require a 1.1 mm cryoprobe to take a biopsy. So this is the steps of doing an EBUS cryobiopsy. Obviously, you first have to identify the lymph node, the largest lymph node with less vessels we identify. Then you identify the biopsy site. Then you do a conventional TBNA and you create a tract. So the several techniques which have been described to create a tract. One, to use a 21G needle only, but multiple punctures. Same area, you do multiple punctures, fast punctures, and then you can create a tract. Most easy technique is to use a 19G needle. If you have a 19G needle, thicker needle, you create puncture 2 or 3 times, then you create a tract through which a cryoprobe can go. Or people have also used electrocautery knife. You can put the cautery knife through the channel of the EBUS scope and then make a tract. Or you can do a EBUS with a 21G needle. You will identify the point where the needle has entered as a red dot. Then you put a conventional bronchoscope, then put a cautery knife and then create a tract. However, this is little more challenging. Once you create a tract, you fix the scope and through the tract you pass a cryoprobe under vision, then activate it for 47 seconds and then remove the whole scope and the cryoprobe outside and then take the tissue. I'll show some videos also as to how it is done. This is one video. So the first step is to create a tract. If you can see here, this is a 19G needle. You can appreciate it that it is much more echogenic than the conventional needles. So you pass, you do multiple jabs. If you can see here, multiple jabs are being done. Then you pass the cryoprobe. If you can see here, now the cryoprobe is going inside. You can see only the tip of the cryoprobe is echogenic. The remaining, the shaft is not echogenic. You put a Doppler, look for the presence or absence of vessels at that point, freeze for anywhere between 4 to 7 seconds, and while we are freezing, pull it out. So this is the type of pieces we get. You can see each piece is around 3 mm in diameter. So if you take 4 pieces, then you will get around 1 centimeter of lymph node out for diagnosis. And this is very, very big. So the first paper had come out from the Chinese. Then I'll be sharing some of our data on EBUS cryobiopsy. So this is a paper which we had published in JOBIP last year. So what we had done is, this is our experience over 5 months. All cases of EBUS, we did conventional EBUS TBNA, we did a rapid onset evaluation. So when the pathologist said the sample was non-diagnostic or inadequate, then on the same time we did a cryobiopsy. So this is how we planned the study, and we have found that when we do it in a case where we have non-diagnostic rows, it has a diagnostic yield of 71%. That is where EBUS rows is inconclusive. If you do cryo, 71% of the times you can get a diagnosis. The tissue obtained is adequate for all molecular markers, and it also has an acceptable safety profile, with the only complication being a self-limiting bleed. This is the study flow of the patients. 196 patients, EBUS was performed. In 150 patients, the normal TBNA was sufficient. In 46 patients, rows was inconclusive. Then we did EBUS cryobiopsy in 32 patients, where the EBUS was non-diagnostic, not for inadequate. For 14 patients, it was diagnostic but inadequate. In 32 patients, it was non-diagnostic. Inadequate means you had tumor cells, but they were very scant tumor cells. So in these 32 patients, in 5 patients, the final TBNA was conclusive. In 27 patients, the conventional EBUS TBNA was completely inconclusive, and 13 of them, the cryobiopsy gave us a diagnosis. This is the review of literature which we had done since the first article which had come about a couple of years ago. If you can see the data, most studies have shown that the diagnostic yield is around 90% to 100%. So the proposed algorithm after this study is that you don't do for every patient. We do EBUS, we do rapid onset evaluation, and if rapid onset evaluation is satisfactory diagnostic, you don't have to do cryobiopsy. If it is non-diagnostic or if it is inadequate aspirate, we do a cryobiopsy. If cryobiopsy is diagnostic, we are happy. If that also is non-diagnostic, then you can think of a mediastinoscopy. So now between an EBUS and mediastinoscopy, you have a new step called as an EBUS biopsy. This is another study which we have recently done, presented in our National Congress, and we have got the best paper award for this. This has been sent for publication, probably will be online in a couple of months. So now we have three techniques to do EBUS biopsy: the needle biopsy, the forceps biopsy, and the cryobiopsy. Now which is better? This is what we wanted to answer. So this is a study where we compared the acquired biopsy with the cryobiopsy. So 42 patients, consecutive patients, 12 patients were excluded because they were small nodes less than 1 centimeter or the patient did not give consent. 30 patients consecutive, we have done both acquired biopsy, that is the needle biopsy, and the cryobiopsy. So the Francine biopsy is the acquired biopsy in 30 patients. All 30 patients we got a core. In cryobiopsy, 2 patients we could not get a cryo because of the angulation. The results were very impressive. You can see the diagnostic yield of cryobiopsy is much better than the acquired needle biopsy. 93 versus 73%, p-value is significant. Sample adequacy for molecular studies, again better with cryobiopsy as compared with the acquired needle biopsy. The granuloma yield also is much better with the cryobiopsy as compared to the acquired biopsy. The duration again is similar, almost similar for both of them. It just takes around 15 minutes for doing these biopsy procedures. The bleeding, the minor bleed is more with cryo as compared to acquired, but this is not life-threatening. Crush artifacts are more with the acquired needle biopsy as compared to cryo. Cryo will get a very pristine biopsy. So this is the images of the histopathology. You can see cryo will get larger pieces and better diagnostic yield as compared to the acquired. So with this study, we concluded that definitely cryobiopsy is superior to the needle biopsy with the acquired needle with an acceptable safety profile. And it can be considered an alternative. However, if you do not have cryo, mini cryo, if you do not have ability to create a tract, then you can use an acquired needle biopsy. It is definitely better than a TBNA, but lesser than a cryobiopsy. Now coming to the complications of these biopsy techniques, mild bleeding is something which has been reported. This is not something which you have to be concerned about. Some vague cases of pneumothorax and pneumomediastinum. The advantages of a cryobiopsy is that we get a larger tissue as compared to other techniques, lesser artifacts, better diagnostic yield, and documented safety. The disadvantages of this technique are that you need to have an artificial airway because you have to remove the scope multiple times in and out. The time taken is little longer than the conventional TBNA. And we can only sample from one path. So you create a tract and only through the tract you go. You do not go into multiple parts of the lymph node. It obviously requires extra tools to create a tract and a cryoprobe and increase cost of the procedure. Now comparing these techniques, this is one of the pre-last slides. We can see needle biopsy, forceps biopsy, cryobiopsy. For both forceps and cryo, you have to create a tract. So you need techniques and tools to create a tract. Size of the biopsy, the largest is with cryobiopsy, followed by needle and then the forceps biopsy. Crush artifacts are highest with the forceps biopsy. And ability to sample different areas within the node. It's possible only with the needle. So with the needle, you can do multiple areas you can puncture, but with cryo and forceps, same area you have to go. This is the comparison, and this is the algorithm at our center now. So we always do EBUS with rows. If rows is sufficient, then we do not do biopsy. But if rows is inconclusive or inadequate, we do EBUS biopsy at the same time. Now we more often than not use cryobiopsy as compared to other techniques. So just to summarize, EBUS biopsy is going to be the new normal. There are various techniques to obtain biopsy samples. Of these, the most promising are the EBUS mediastinal cryobiopsy and the EBUS acquired needle biopsy. However, we need more and more data, more scientific data before it becomes a norm. Thank you so much, and thank you once again, dear Dr. Haitham.
by the end of this session, we'd like to thank Dr. Nagorjora Matora for his comprehensive overview and just addressing the role and the rising role of the biopsy using the EBUS for the mediastinal lymph nodes. And we are closing by this session. It's 2:50. We got only 15 minutes for the coffee break because of we are in a delay of time. And to be back, inshallah, بإذن الله الساعة 3 و 5 to start the upcoming session. Thank you.